Hi, I'm Steve Selig, founder of FitTest, and in part two of my series on permanent pacemakers and implantable cardiac defibrillators for exercise professionals. In this video, I'm going to just talk about implantable cardiac defibrillators and just provide some of the basics around these implantable devices. So first of all, just to describe what an implantable cardiac defibrillator looks like, and in particular, I'm just going to concentrate on those that also have pacing capacity as well. And so the device I want to talk about is called cardiac resynchronization therapy plus defibrillator, or CRT-D device. And these are quite common in I'll show you the indications, but people with heart failure who are at danger of cardiac arrest and other conditions. So we have a pacing lead in the right atrium. We have a defibrillation lead in the right ventricle that also paces and senses and so on. And we have what on here designated as a coronary venous lead, but this is effectively a sensing and pacing lead over in the left ventricle, and the access for this lead has come from the coronary sinus system, hence called coronary venous lead. But it's essentially a left ventricular free wall sensing and pacing lead. Now, the indications for ICDs are to prevent sudden death in patients with known or sustained ventricular tachycardia or episodes of ventricular fibrillation, to have survived a sudden cardiac arrest, to have some of the congenital conditions that I'll talk about now, so long QT syndrome, which can lead to lethal arrhythmias. It's a fairly difficult syndrome to diagnose fully and then treat very effectively. So these patients can be at risk of sudden cardiac death through lethal arrhythmias, and so the ICDs are fitted. Brugada syndrome, similarly a congenital disease made up of a syndrome or a collection of sodium channelopathies, again leading to the potential for lethal arrhythmias. And in Brugada syndrome, the ECG criteria for one of the main types, there are a number of manifestations of Brugada, but I've just illustrated one of the main types here. In fact, this is type 1 Brugada, where you have a coved ST segment in the anterior leads V1 to V3. So this is very typical recording for a V2 lead, where this coved ST segment shouldn't be there, and that's related to sodium channelopathy. And finally on this list, it's not a complete list, but it'll give you an idea, congenital cardiomyopathies, especially hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy. So we now come to exercise for people with ICDs. And the first thing that you may come across is that clients with ICDs worry that exercise could trigger an arrhythmia or a very high heart rate that might result in a painful, unnecessary ICD shock. And so there's some avoidance of exercise, which then denies them a lot of the health benefits of exercise if they go down that path. However, the evidence is that ICD shocks are uncommon during exercise itself. I've given you the references down below if you want to look further into the evidence. It's not that they don't occur, but they're just uncommon, and that's really the way to express that. But I'll have more to say on that issue in a minute. There is evidence published in both of those papers that in fit individuals who have ICDs implanted, there's a reduced risk of shocks for the rest of the day, that is when they're not exercising. So that should tip the risk-benefit ratio over towards the benefit side of the equation. These authors strongly recommend, and a number of authors strongly recommend, cardiac rehabilitation after ICD implantation to help clients to reduce their fear of exercise shocks. Now, it's really important that we exercise professionals know something about defibrillation thresholds. there are complex settings on ICDs that will trigger a defib shock. And the settings depend on the ICD to learn the patient's native rate, rhythm, and ECG morphology, and so that the ICD shocks are only put in for life-threatening rates and rhythms. The ICD learns to discriminate between various tachycardias and tachyarrhythmias, for example, atrial fibrillation, supraventricular tachycardias, ventricular tachycardias, and ventricular fibrillation. In the case of VT, the ICD will attempt to pace at a rate above the VT pace to try and break the VT rate and rhythm and put someone back in either into sinus rhythm or into a healthier paced rhythm. Now, exercise professionals must know the heart rate threshold for the particular ICD for that client and just stay with a good margin for error well below that heart rate threshold. So if you don't know it when you get a referral or you get a client with an ICD, you need to find out by going back to the referring medical practitioner or another health professional to get that information. That's really important. So continuing on with that same point, most forms of physical activities can be performed by patients with an ICD. However, the strong recommendation is to avoid body contact or combat sports, as this could damage both the computer itself or any part of the pacing, sensing, and defibrillation leads. Do not put excessive strain on the shoulder, arm, and torso, the arm on that side of the body, and torso area where the ICD is implanted. Doing so may damage the ICD or the leads going from the ICD generator to the patient's heart. Particularly avoid exercises that cause the clavicle or collarbone to be pulled down towards the ribs, such as lifting weights with the arm on the ICD site while standing. If the client has had previous shocks related to exercise, then make sure that these are accounted for and avoid these forms of exercise or triggers. That just makes common sense. So thank you for listening to this short video on implantable cardiac defibrillators. You can contact me at info@myfittest.com.au. Bye for now.